put a little image up there that says stop scrolling and go practice, right? And so that means a lot of different things, but what I'm trying to come across is that we have a practice of medicine, right? And even though we're not physicians, we're still out there performing medicine, especially in the critical care sphere that we operate in. And so, you know, it's good for us to get together in times like this to review cases, to go over certain things, and just make sure that we are on the up and up when it comes to practicing this kind of medicine to our patients, because it can be so dynamic and needs to be so thorough in order to make sure we take care of our patients correctly. So to that end, today's agenda, we're going to take a case and review that. It's a case that was really interesting. It was ran about 4 or 5 weeks ago now by 2 of our signal resource crew members. One of them is here today, Nick. The other one, Greg Rupp, couldn't make it. He's got a sick kid at home. But we're going to discuss that, break it down, see what happened, maybe some lessons learned and some things we can improve on in the future. We're going to do a critical care spotlight. I'm going to try to do that every week, or every month we do this. Today is going to be a Nicardipine, because we've given 2 Nicardipine infusions in the field now on IFTs. One of them being Donnie, who's here today. Maybe he can talk about his experience. The other one being Adam Schlosser, and I think he was coming today. Hopefully he'll show up. And then also we'll do a little ventilator practice. And so one of you is going to have to put me on CPAP and administer an in-line nebulized treatment. So one of you have to do it, in the words of the great L. Ron, okay? So then we'll do that. And then eventually after that, we'll get into the Hamilton 900. I'm going to demo it. And then this afternoon, the Hamilton people will be here to kind of go over it thoroughly. Dr. Tanya, of course, is here as well. He's going to supplement, or really, he's going to give all the good stuff. I'm just going to go through the slides, and Dr. Tanya is going to interject from time to time and give us his knowledge and wisdom. Okay, any questions before we go on? Here we go. So case 1. So we have a critical care transfer that was done around 4 to 5 weeks ago. This patient was I guess I can say the age, not HIPAA, 37-year-old female, right? It was a younger individual who was being transferred from an ICU here in the county downtown to an ICU with invasive ventilation. She had a brachial arterial line. They were administering Flolan via the ET tube, and she had vasopressin, Levophed. Was that Levophed high dose? Do you remember? It didn't say it in the notes in the narrative, but okay, either way. Propofol, Nimbex, sodium bicarb, fentanyl, and vancomycin. So.
Hold on, I'm not trying to slow you down here, but I don't see this as much as you guys do, but I am seeing vasopressin piggyback with Levophed a lot more than I've ever seen it.
Yeah.
So is that something that is more common for you guys?
Oh yeah.
They told us that if their levo is over 0.2, they automatically start vaso, is what Lake told me, I think.
There's a guideline there. Dr. Chan, can you speak more to that? I think it's physician and patient dependent, obviously.
Yeah,
but
we don't have any such, at least at big bars, like if it's more than 0.2, we have to start vaso.
okay. But I have heard that the physicians are specific on it, and they will throw in. And why, right? What's the point of it? Why are we starting vasopressin instead of upping up norepinephrine to the max?
I would just,
Yeah.
you're hitting a different.
Yeah, and so that makes sense. And so I think that's what they're trying to do, because they're going to get better hemodynamic support by hitting multiple pressors and not wearing out a specific receptor. And so she was paralyzed, obviously, with the Nimbex, and she was sedated with the propofol and a fentanyl infusion. So, you know, we've seen worse. We've seen patients with much more infusions than that, but she's pretty sick. History of present illness. She did arrive to the ER first via EMS, complaining of shortness of breath with a history of ETOH. She presented in the ER with pulmonary edema, and they placed her on CPAP. I don't know how long it took, but she did decompensate, and the patient was subsequently intubated in the ER. Forget about the cardiac arrest, because I couldn't figure out if she arrested in the ER or in the ICU, but it turns out she arrested in the ICU, so she didn't arrest in the ER. In the ER, they placed her on the Hamilton and had no success. They couldn't get her dialed in because of the massive copious secretions going on. That's going to play a big factor in this call. They tried several modes, including CMV, ASV, and pressure, each resulting in the insufficiency of able to move that fluid forward and then clear it and getting good end-tidal and SpO2 readings. They just couldn't get it. The patient was then removed from the ventilator and supported with BVM with high PEEPs. And they were, at that time, right, able to control the secretions a little better, not on the ventilator, but on the BVM with the PEEP valve turned up high, which is interesting. We'll talk about that. So the patient was then admitted to the ICU, and this was the initial ABG. Now, who can interpret that for me? Got a pH of 6.96, which is massively low, obviously. PCO2, PO2, what's going on here? Yep, so first of all, what's the P to F ratio? What is it? It's 89, right? How do we do that? Well, we know the patient's on 100% FiO2. We divide that into the PO2. Her PF ratio is 89. So she's in severe respiratory problems despite being on 100% FiO2, right? And if you remember, a patient normally like you and I, if I was placed on a FiO2 of 100% and my PaO2 is normal in the 80s, what would you expect my PaO2 to do? Bump to 400. But she's on 100% FiO2 and her PaO2 is 89. So you would say, oh, she's doing good. Her PaO2 is within the normal limits. But is she? Far from it. Far from it. And that's the benefit of getting a P to F ratio, because that tells you, oh, despite the fact that it's a normal range of PaO2, she's still having a lot of problems with oxygenation, right? Which is going to translate downstream, right? So just like Sean just said, we do have an acidosis, but we have a mixed acidotic disorder. Why am I saying that? What's giving that away? Well, obviously the pH is acidotic. What's the PCO2 telling us?
Your PCO2 and your bicarb are
They're both acidotic, aren't they? So we've got a...
alcohol and the breathing issues.
Yeah, oh, we'll play into that. We'll figure that out. But yeah, she's got a dual disorder at the very least. She's got a respiratory and a metabolic acidosis. Which is primary, though? In this case, would it be a primary metabolic or primary respiratory?
Metabolic, or is it bicarb?
Yeah, you would think that, but actually it's an acute respiratory acidosis, given the history of the patient. But she does have a secondary metabolic acidosis, and she also has an additional non-ion gap metabolic acidosis. So she's got a triple. She's won the triple crown. She is extremely sick. Obviously, with the pH 6.96, she's not going anywhere quick. But she's very sick. She's got three disorders going on all at the same time. So let's do a little more investigation. I know as critical care providers, what are we asked to do? We're asked to look at this ABG, evaluate that, but that's not the end of the story, is it? We need to take a look at the lab work and see exactly what's going on with the patient. And so they did their labs. We've got a blood glucose of 125. Are we happy with that?
Yeah.
Okay. What about a sodium 134?
Yeah.
Okay. What about a potassium of 3.6? What's the range for potassium?
I always look at 3.
Yeah, 3, 5 to 5,
Okay.
right? So it's okay. It's a little on the low side. Chloride is 104. Are we okay with that? Yeah, that's within range, right? 105 is the max, so it's a little high. The anion gap is 15. How do we feel about that?
Right, that's eliminated.
Yeah, it depends on where you go, but generally we're looking for an anion gap under what? 20. Generally. So this patient doesn't necessarily yet have a high anion gap metabolic acidosis. Now looking at her BUN and creatinine, which is a function of which organ? Kidney. So we're looking at kidney function. How are the ranges?
Creatinine looks low.
No, creatinine is 0.6 to 1.2. What's our BUN range?
Like less than 20?
Yeah, 8 to 22, somewhere in that range. So the kidney function is fine. However, look at the A numbers, right? The ALT and the AST, right? So what should be the ranges to be there? The ALT should be like 7 to 50, 60 or 99. AST, 10 to 40, right? So we are extreme, have really abnormal liver function parameters, don't we? So we have some liver function failure, right? Some liver failure,
I don't
liver
see
problems.
those. Remember, I don't see much. What was the ALT and the AST again? What are the markers?
So the ALT is 7 to 50 and the AST is 10 to 40. Is that about right, Dr. Tan, would you say? We're just talking about the ranges for ALT, that they're very high, right? This is very high.
Oh, yes.
That's super elevated.
ALT is not super high, but it's elevated.
AST is massively high, yeah.
And what's the range for the AST again?
AST is like 10 to 40, right, Doc Tan?
Yeah, it's in the lower one.
Yeah. Okay, but what gives this away as a problem is the albumin. Okay, I want you guys to think about the albumin. Okay, this is a critical care function. It's not the same. I just don't want you to look at those liver function values. Always look at the albumin. And that's going to tell you the severity of the problem that's going on, either the kidney or the liver dysfunction. So this patient has liver dysfunction with an albumin of 2.7. Is that high, low, normal? Low. It's low. And so why does that matter? Why are we worried about the albumin? What's so important about the albumin? What is albumin? What does it do in the body? Remember, it's a macromolecule. It's a protein.
Maintain like
Yes.
most fluid in the
Yes. So it operates with oncotic pressure, right? And so what does oncotic pressure mean? Remember from school? I like to think of oncotic pressure like a black hole, right? So these protein molecules are black holes traveling through the body. And if you get too close to a black hole, it's going to suck you in. You ain't getting out of that, right? You're just over, right? So what it's doing is as it travels through the body, it's distributing water from extracellular or intracellular to intravascular, and the water has no choice but to pull into the intravascular space because of the black hole that's traveling through it. We've increased the concentration of black holes by giving albumin, or a patient has albumin. So what's going on here is what they're doing is they're losing. There's a problem, right? There's a problem maintaining acid balance base. There's a problem maintaining volume, right, in the patient, right? And so the oncotic pressure is low. We're going to have a problem with perfusion as a result of that. And we've got liver dysfunction to begin with. So this patient's pretty sick.
What's normal range for albumin?
Oh, crap. Dr. Tam.
Albumin is 3.5 to 5.5, right? 3.5 to 5.5?
I was gonna say 4.
4, okay. That sounds right. Yeah, exactly. I remember that now. Yeah, 4. So how low have you seen albumin get in a critical patient, Dr. Tam?
I've seen like 2-ish.
2-ish?
Yeah. And remember the other thing, AST, ALT, they call it hepatic function, but that's not really function, it's just an enzyme. It's more of showing like hepatic damage. So we don't call troponin a cardiac function test,
Okay.
right? So
Yeah.
we shouldn't call it AST, ALT hepatic function test. Albumin, however, is.
Albumin is more so.
It's
Okay.
because
Okay.
The liver is
Yeah.
what's most responsible.
Because it makes albumin.
It makes the
Yeah.
albumin. And so truly, when that's low, you know that there's enough true liver dysfunction that they're hypoalbuminemic, and that's what's going to contribute to that.
Okay.
Capillary leakage, a low oncotic pressure, all that kind of thing.
Yeah.
And the other one, of course, being INR.
Oh, the INR, sure.
LLT.
Yeah, that wasn't reported on the narrative, but yeah.
Would you, okay, maybe this is going to sound really bad, but remember, I'm partly a fireman. But would you give plasma? If albumin is prevalent in our plasma, could we?
I would just give albumin.
Right.
If they need
Or just give albumin?
Yeah, I would
Yeah.
just give albumin.
Yeah, albumin is a blood product, right? It's a blood derivative, right? So isn't it considered
It's not a blood product, it's just a large macro.
Okay, so it's just large macromolecule that goes in the blood basically. Okay. Okay, cool. And so knowing all of that, so we know that patient's super sick, she's got all this liver dysfunction, albumin is low. When we look at the anion gap, I told you it was a non-anion gap metabolic acidosis, but how did I get there? Remember, to get to the anion gap, we take our positives minus our negatives, right? And the reason why is because the body wants to maintain what? Electroneutrality, right? Between the positive and negative ions in the body. And so that is how we know we've got an anion gap disturbance, because if a foreign substance is put into the body, these are negative ions, right? And so what's going to happen is it's going to throw off the total negative ions, because the body is only going to go as high with negative as it is high in positive. And so if it gets more negative, the body's going to say, nope, 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 nope. And so something in the negative sphere has to give way to make room for that, right? And so that's an ion gap. So if we look at our positives, which are the sodium, which is 134, minus the addition of both the negatives, which is 104, 104, which is 118. We subtract 134 minus the total negatives, we get an anion gap of 16, and the lab work was reporting 15. So our calculation is accurate with their calculation. So there is no obvious anion gap problem, because the patient hasn't ingested anything that would cause an anion gap, or had a condition right now that's associated with an anion gap acidosis. Still very, very sick, obviously. So while in the ICU, the patient became more hemodynamically unstable. You would expect that for this patient by this point. Was placed on vasoactive medication support. They also did a chest CT, whatever they did, recognized bilateral opacities in the lungs, that ventilation was improving, and they decided she's got ARDS. So they gave her Flolan, they proned her, and they paralysis. They did a secondary follow-up ABG, and that's what we see. And so where do we see, was there any improvement made? Okay, the pH has gone up. We're still acidotic, but look at that PaO2. That's a little scary. And so there you can see now the evidence of them fighting her airway and the copious secretions. They just could not get it under control. And so now we're seeing evidence of downstream problems, right? She's obviously hypoxic now. But it's far from over. The patient continued to have pulmonary secretions that were copious. They would actually pour out of the ET tube. They were so copious. Clogging the filters, clogging the flow centers on the ventilator tubing. This is a mess.
Is that because of the albumin being so low too with the capillary leak? Is that why we're getting another?
I think it's a factor of that and a lot of other physiological factors that are starting to cascade. She's in a circle now, right? She's in a circle of problems where she's going to have a big problem. They're going to have a fight to bring her back from this. Would you agree, Dr. Tan? Yeah, she's really circling the drain. So on the ventilator, in under these current conditions, the best they can get for SpO2 is 60 to 70%. So the crew received feedback, the crew arrived, received feedback that they're only aiming for about 70%, right, Nick, is what they told you? Said, look, if you can get to 70, you're good.
The late physician was on the phone with the Stewart physician.
Yeah.
When he said that.
Yeah. And so they knew they couldn't do much about it. Why? Because the patient was going to go on ECMO, obviously, to take the lungs out of the equation and let's get things fixed. VV ECMO. That was the purpose of the transfer. In the ICU, the crew helped out, obviously, provided treatment. They utilized BVM and they suctioned the patient constantly, but suctioning did nothing right because of, I guess, there's a lot of factors that play into that with different pressures, intrathoracic pressures, and the fluid flow and different things like that, but they couldn't get it under control with suctioning. During transport, they did place the patient on the ventilator to trial it. They were able to get up to the high 70s. However, they weren't sure about the SpO2 being accurate because of the vasoactive medications. Patients' extremities were cool, and they weren't sure about the accuracy of the SpO2, right? And obviously, we can't do an ABG during transport to see what the PaO2 is. They tried PCV initially, so they tried a pressure control of 20. They were getting exhaled tidal volumes around 300. They had a high respiratory rate, high FiO2, and high PEEP. When they went to change between the BVM and the ventilator, they clamped the tube every time. Who can tell me the benefit of them doing that?
Yeah, you don't want to just leave it to open air. I mean, you're losing the pressure that you had in the recruitment that you got.
Exactly. Now, what did the ER staff do? They didn't do that, did they? So between changes, between the ventilator and the BVM, they didn't clamp the tube at all. So was there any wonder why the SpO2 crashed in the 50s whenever they made a change? No wonder, right? Yeah. And then they haven't told, what was the comment they made to you, Nick, when they saw you clamp the tube?
Yeah, they just said they've never seen that before.
Never seen that before.
We clamp it if we're switching from the BVM to the vent.
Yes.
Even if it was
yes.
just a minute.
I think it's good practice. We're going to buy large forceps for all you 64 people to put in your bags individually so you have them. But we'll get you those. But unfortunately, though, just like in the ICU, the patient was not able to be kept on the ventilator because they couldn't stop the forward flow out of copious secretions. And so it was clogging things up. SpO2 dropped to the 50s. Again, we don't know if that was accurate, but probably was. Their vital signs, though, weren't bad, considering the patient. 100 over 50, 115, 145 over 45, 135 over 35. But on the surface, they don't look bad, but are they bad?
Yeah.
And what's so bad about those vital signs?
Shock index. Yeah.
Okay, one is the shock index. What else? Wide pulse pressure. Dude, should we ever have a pulse pressure of 90? No, not ever. I don't even know if that last blood pressure is accurate. A pulse pressure of 100? I mean, gee, Merry Christmas. And so when we have a patient that has such a wide pulse pressure, that's telling us something. The blood pressure is tattletailing, right? And so our normal pulse pressure on any patient is what? It's 40 to 60, right? That's where we live. Blood pressure is measuring what? It's measuring vascular resistance, right? It's measuring how well blood's flowing through the vasculature. So if I've got a problem with the pulse pressure up or down, I'm going to see evidence of that, and it may point to a certain condition. So this is a patient with poor vascular compliance. This patient has low SVR. And I'm just speculating here, but I would assume that this is probably from vasoplegia, right? So her blood vessels now are not responding appropriately. They're super dilated for the condition she's in. And now we've got problems with the low diastolic pressure because she's so vasoplagic, right? And so another reason why they put a vasopressor on to kind of reverse that and help that. This results in what? It's not just a bad number. It results in low stroke volumes and low cardiac output, which equals what at the cellular level? This is adding more hypoxia to the cellular level, right? So as critical care clinicians, guys, we just don't want you to take a blood pressure and go, well, that looks normal. We want you to assess the blood pressure, every blood pressure. And these weren't art line pressures. I don't remember seeing art line pressures on the narrative, but I guess maybe he didn't put them in. These were manual pressures, correct? Or where were these art line pressures, Nick? Do you remember?
I don't know if you switched them over.
Okay. So they may be incorrect. They may have been manual pressures or just maybe a little bit incorrect readings. But if these were art line pressures, then obviously they're very accurate and the patient's got severe vasoplasia and vasodilation and is having, obviously she's very sick. We don't need to, but you can tell she's in really bad shape. All right, so that's my review of reading the narrative. We have Nick here with us. Nick was on the call with Greg. And so Nick, kind of tell us about, what you did, why you did it, add to the narrative that I didn't already add, and how you managed each thing as it came, as a patient as a whole, holistically, and any lessons that you may have learned or anything we could have done differently in the future.
For context, in the span of like 90 seconds, 2 critical care transfers came out of Lake St. Louis. Greg was on 64, so it was him and a 800 series unit on this call, and I was dispatched to the ER for a brain bleed, and we met Greg outside the ER, got there about the same time, and just based on the notes, I was like, hey, I'm gonna go upstairs with you and see what's up with this, because it's not often you see that a patient being transferred from ICU to ICU is being bagged in the notes. So I ended up going, my truck ended up going with Greg and another 800 series unit, and then I think you came and took the brain bleed out of the ER. So we had 2 trucks and Greg on this call because we needed the hands, which was a good decision. She presented, I believe she did arrest in the ER, if not in the ICU as well, but I'm pretty sure she arrested in the ER initially with unibation. Like you said, they tried her on a bunch of different settings with the ventilator. They tried her with high peeps, low volume, and high ventilatory rates. They tried to invert her IDE ratio with little to no success, and then ended up bagging her for 2 or 3 hours before we got there. Sounded like they've been bagging her for a while. When we got up to the room, it was a little chaotic, as it tends to happen. There were 2 or 3 respiratory therapists in there that were working on trying to do things with her airway, between bagging and pretty frequent, like every few breaths with an inline suction. And they had her at a PEEP of 10 at the time. She also, I don't know if this was, it's left out of the narrative, but had massive, tight abdomen. It was very, very full. A lot of ascites, yeah, which tracks with the liver and her history and everything else. So I think that, compounded adding issues to her airway. I'm sure, yeah, the intubation and I'm sure ventilator success and everything else like that. So we had some things to sort out when we got there. They had their arterial line, but the transducer was not placed anywhere. It was just kind of hanging. So our pressures that we were guiding vasoactive therapy off of weren't accurate. So we had already some challenges just to get everything kind of at normal. It's mentioned in here, the secretions had basically filled any thing that was reading stuff, end tidal or the ventilator. So we had to switch out a bunch of that stuff to try to get it clean. We talked about the SpO2. He was on the phone with the receiving physician when he made that comment to us about just being happy keeping it above 70%. Again, not sure how reliable SpO2s were in that case anyway. And part of the reason, obviously we're bagging, so we need extra hands, but also one pump was alarming because it was dying and not plugged in. The Flowlan will not run if it's not plugged in.
And that's important to notice that during the transit from the room to the truck, you have no flowing and flowing.
Correct, because it needs to be plugged in. There's no battery on that item. Bagging her was relatively easy. I don't think there were major issues with compliance that you wouldn't expect. We did trial her on the vent a couple times with pretty aggressive settings because we knew to an extent what we were dealing with. Clamp the tube. Both times when it was switched over, we had 3 or 4 people in the back, so we're hot swapping things pretty quickly. So there wasn't a lot of downtime, you know, with between the BVM and the vent and stuff like that. Even with all that, the vent was not doing well, and one thing that Greg mentions here is that it maybe didn't have enough time to kind of calibrate itself to the patient, given that she had some pretty tough pressures to deal with. But it was not outputting much at all for tidal volume.
So
and
you were in pressure, you were in PCB or CMB plus, or PRDC?
We tried 2, I can't remember.
In both modes you couldn't
In
get
both, it was the same result both times.
Okay.
Yeah, we tried 2 different
Do you remember what the
approaches.
acceptable timelines were at that point?
Like tens in the less than hundreds.
Less than hundreds?
Less than hundreds, yeah.
Okay.
We
With
did
a
not
pressure
try-
score of 20, a pressure control of 20.
Yeah,
Yeah,
and a PEEP of 20.
and PEEP 20.
So before all that, or in the midst of all that, at some point we went from a PEEP of 10 up to 15 and then up to 20, and that helped us with the secretions. And that's where I think that 70 to 78 comes from, that's in the
'Cause you're able to-
narrative, because I think the pressure is really what she needed there. But even with all that, we did not give her very long on the vent either of these times, like a handful of breaths, because she would desat incredibly quickly from the mid-70s to the 50s in the span of like 10 or 15 seconds.
So you guys had inline suction, right, for your?
Inline suction, yeah, so we didn't have to break the pressure for that. I don't remember if she was prone at the time or not. I don't think she was. I know they proned her earlier, but I think she was supine for us.
They didn't prone her out for your transport?
No, I think she had been prone, but when we got there, she was supinated, yeah. So we did trial her on the vent. That was in addition to what they'd done in the ER and ICU, and just had not a long runway to our success with that, so we didn't trial it very long. We did go up to 20 total on that PEEP with the BVM, which seemed to be helpful, and among other things on the way. So when we got to the receiving ICU, Greg gave a thorough report of what we'd been dealing with, as well as what we'd tried and been unsuccessful with. Really trying to emphasize the fact that, because we know when we get to an ICU, they're going to want to put her on the vent. Really tried to make that point to them. It did not come across as
They did what they're going to do.
they did what they're going to do. We got everything switched over, got her on their bed, and they decided to switch her onto their vent. I can't remember the vent settings, but they were not even as aggressive as what we'd done. And her SpO2 tanked, as it had every other time. She braided down, and they ended up running an arrest on her. I don't remember if it was just a Brady ICU arrest or if it was actually a pulseless arrest. They ran it for like 8 minutes or something, gave an epi and a bicarb, and got her back, and then bagged her. And then when they were trying to put her on the vent again, one of the physicians cranked the PEEP up to 30, and that was about the only thing that we'd seen with the vent that was effective at getting the volumes and the ventilation that she needed.
So at one point, she had a diastolic of 35, so I mean, she's barely perfusing her heart. So yeah, the drug problem that I would worry about the most, however, is alcohol. Nick, you said her abdomen was tight, like super tight, and they thought it was ascites. And you know that that's not helping her ventilation management at all. And so I assume they had an NG to decompress her stomach as much as possible. Do you remember?
I'm not certain they did.
It wasn't put to suction during transport anyway, right? Or in the ICU.
So that's two things that I'm wondering if that side of the equation, the hospital might have been able to be more aggressive with, because who knows how much distension she had gastric-wise on top of ascites, essentially almost creating an abdominal compartment syndrome. And so I think decompressing the stomach and doing a not just diagnostic, but a therapeutic paracentesis and taking several liters of fluid off may have in fact really helped a lot as far as her ventilation management, her blood pressures even may have been improved, because who knows what her venous return was with a pressure like that. So I've seen a lot of ARDS patients, and I got to tell you, this is probably one of the worst numbers-wise I've seen in a long time, and this is really, really bad.
Despite the complications that you obviously couldn't manage in the back of an ambulance, I think they did very well. It was well managed as much as possible. They got the patient there alive. The patient did go through ECMO, but ended up succumbing to her illnesses later in the hospital.
How long? Was it the next day or?
A couple of days, I want to say. I'm not exactly sure, but no huge surprise. But you know what? We did our job is to do to bridge the gap, right? And so a lot of times we bridge the gap from the ER to the ICU as critical care clinicians. Here it was from ICU to ICU, but we bridged that gap, right? We didn't cause harm. We got her there in the best condition we could, and we managed everything that came along as best we could. So I think it was a job well done on you guys' part. I do want to take a few minutes, and Dr. Tan is able to jump in here as well. Let's just talk a little bit about the pathophysiology behind the state, and then just kind of remind ourselves what it is, because with winter coming, it's going to be a bad winter. We're going to have a lot more ventilated patients that are going to have a lot of different conditions, and so it'd be good to remind ourselves about compliance. So compliance, simply put, is the pressure, the change in volume and pressure that's in that filled space, right? So it's about the ability to inflate in relation to the pressure that's needed to move air in and out. So a balloon is a good example of that. In the middle, that's a normally filled balloon. It's got good compliance. If I'm able to put more air in there pretty easily because it can expand when needed. And the other balloon, it's kind of crumpled down because it's not able to take a whole lot of air. If I put more air in that balloon, it's going to be a problem. It's going to increase the pressures with very little volume. And then the right side, this is a very highly compliant lung. So it's overfilled already, but it'd take even more air because a balloon can able to stretch even more, but that's not necessarily a good thing, is it? Right, and so the ones on the extremes on either sides have their own disadvantages. And we'll talk a little bit more about that. So in compliance, if you have a patient with a high compliance, that means they've got too much stretch, they're overdistended, and they're going to enlarge their alveoli. Now, what kind of medical condition would we associate on somebody who has high compliance?
Asthma?
Not asthma necessarily.
End-stage COPD.
Yeah, so end-stage COPD is right. They've got that barrel chest because the alveoli have shaped themselves to retention of that air for so long that now it looks like a barrel chest. And those alveoli are distended, they're enlarged. And so what can happen is you can give a lot more pressures into those alveoli and not even realize you're doing any harm because the lungs are able to take it because they're able to be stretched. It's like a rubber band that I shoot 1,000,000 times. When I shot it 1,000,000 times, it's going to be a floppy mess, right? And so I can pull that thing longer, but it's just going to fall out in front of me, so I can go very far because it has no more stretch to it or no more impact, no more forward motion. Conversely, on a low compliance lung, a very tight lung, we call them baby lungs on the ARDS patients, you can't get any stretch out of it. They're underdistended and they're even collapsed, right? And so if you've got a high compliant lung on the left, a large volume will impact a small pressure, right? So, if you give a large volume, your pressure readings back are going to be very small because the lung is able to take it, right? Conversely, on the other side, if I give a small volume and the lung cannot take it, even if it's a small volume, it's going to yield a high pressure. And you guys can see that. And so to define ARDS, there's criteria has been changing. I think in 24 it was. They changed the criteria again, called the New Berlin criteria. And now to diagnose ARDS, they have to be on oxygen therapy at high flow nasal cannula greater than 30 liters a minute, or non-invasive pressure greater than PEEP of 5, which is kind of surprising, but that's what I found online. They have to have a CT or a chest x-ray that reveals bilateral infiltrates, and they need to have a PF ratio if it's mild, under 300, if it's moderate, under 200, if it's severe, under 100. And now they're getting away from the PF ratio and they're going toward an SpO2 FiO2 ratio, which is what we teach in our class, because you can't always have an ABG, so we teach you to correlate the SpO2 with the PaO2, and you can do that loosely, big correlation. Well, that's been extended into the ICU world, and so thank you to us. They should thank us for that, because that's an EMS thing, I think. And now they're looking at it and going, hey, we don't have to get an ABG on every single patient every 5 minutes. We can look at the SpO2, relate that to the FiO2, and get an idea of how well their oxygenation, right? So what is ARDS? ARDS is really, it's a severe disorder in pulmonary vascular permeability, right? So it's a problem not just with the alveoli, guys, it's a problem with the interstitial space and the pulmonary vasculature. It's a mixture of all three, which is why it's so deadly, which is why it's so difficult to maintain and to treat. So it's a dysfunction and a destruction of that AC membrane, right? And that's so vitally important for oxygenation and gas diffusion, right? Remember the Fick principle, I referenced the Fick principle. So what happens is fluid will build up. Now we've got inflammation because white blood cells will respond. It clogs up the alveoli, it clogs up the interstitial space, and that results in alveoli collapse and destruction, right? So in your other respiratory conditions like COPD, there's no alveolar destruction necessarily until much later on. It's the terminal bronchioles that get destroyed in COPD, right? Which prevents blood from exiting the alveoli. It's not alveolar destruction. Asthma, it's not really alveolar destruction either. It's the bronchioles that are dysfunctioned with clogged mucus, and now you can't get air in or out with it because there's the degree of clog. But ours is a completely different story. It really messes with the entire system, the entire picture. So that's why it's the worst pulmonary disorder we can face and be able to manage. A lot of things will cause it, right? And so sepsis, pancreatitis are the big ones, but COVID certainly caused it. A drowning, like we just had a pediatric drowning patient not 2-3 weeks ago. We were supposed to present today, but that's going to be delayed till next time, where the patient actually developed ARDS. And they managed it and he survived it, thank God. 10-year-old, actual drowning, pulseless. And they got him back in the field and transported him. He's made a full recovery. But he did develop ARDS. You can get it from blood transfusions. Now we know that as trally and different things. So remember, ARDS is a hypoxemic respiratory failure. Again, because of the poor compliance. Managing ARDS, well, we have to take in consideration of the lack of space, right? Everything's gunked up, everything's filled up, can't get volume in, right? So we're looking for tidal volumes of 6 to 8. You can go as low as 4. However, they're kind of getting away from that. Only in extreme measures will they go down to 4 now, but they're looking for a 6 to 8 tidal volume. Volume-based too. They're initially going with volume control ventilation for the most part, and then they'll go to other modes after that. They want to obviously keep the P-plot under 30, but the big thing is that driving pressure. We're going to talk about more here in a minute. You want to keep that under 15. PEEP starts at 5, and they'll titrate to oxygenation. It can be as high as 20 and even higher, right? Expect your respiratory rate to be high. Why? To maintain that good minute ventilation. We still, regardless of what's going on, we still made the patient needs to move gases in and out, and so we need a good minute ventilation. Proning, what's the benefit of proning? Well, remember that there's a lot of dependent alveoli in the back of our lungs that because we're upright, we just don't use them very well. When we're laying on our back, we use them even less. And so now when we can turn them over, that opens up those areas that aren't very aerated and able to access those areas through positive pressure. And so we're able to use areas of the lung that may be good for ventilation that normally we would bypass. But since our normal lung alveoli are clogged up, then we're going to rely on this backup space, kind of is the way I think of it. So it actually does help because we can use those alveoli in the back that may not be as involved as the other ones. So it will improve the VQ mismatch. And if you've got a prone patient and you transported them, I always ask them how long they've been proned. because they're supposed to be switched over every so now and then, but we've never had any problem transporting a prone patient here at SCCAD. Double check your ET tube is all I ask. Make sure it's well secured. The patient should be paralyzed if they're prone, obviously, because we don't want them to have respiratory insufficiency trying to battle their own body weight while they're prone, right? So they're going to be paralyzed so we can give them all the support they need while they're laying in a prone position, okay? So make sure they are paralyzed if you're going to prone them, if they're that bad. Reverse IE, that's something we talked about. We need to really consider that. Prolonging that inspiratory phase is really good. This is reverse from COPD. Obviously, COPD, we want to prolong the expiratory phase. If you're going to reverse IE, it's a really good idea to have them paralyzed as well. Again, it's very uncomfortable, and the patient may give you some insufficiency and problems with the ventilator management. So if you're going to reverse that IE, it's good to paralyze them. And that's something that Dr. Tan would support in the field, right? If you've got to do something like that, and they're currently not paralyzed, and you've got dysynchrony in the patient, then please go ahead and paralyze your patient. So you heard it from him yourself.
In fact, ventilator dysynchrony is one of the most correctable causes of taking care of the alarms that you can do, assuming that, of course, that you've got the right sedative on board, et cetera. But yeah, if they're dysynchronous on the ventilator, we need to fix that.
And especially in ARDS, right? Because we've got that problem we're fighting against to begin with, and so we got to get them paralyzed. We got to get them dialed in that vent as much as possible. We do not need dysynchrony in ARDS. Part of that process also is the pulmonary vasodilators, so the prostaglandins play a big role in that. They're going to, like Flolan, you can give that inhaled or IV. Nitric oxide is a very big one too. And so I thought I added another note there, but I guess I didn't. So what's the purpose, what's the benefit of the prostaglandins given is that improves bronchial and alveolar and the pulmonary vascular resistance tone, which improves oxygenation. So what's it do to the PVR, Sean? It reduces the PVR, okay. And so we got to make sure that we understand that. Remember, the pulmonary vasculature is something we need to be mindful of as critical care clinicians. It's not just the systemic vasculature. We got to think about that pulmonary vasculature. And what this is going to do is going to dilate our pulmonary capillaries. But not just that, when it's inhaled, it has a special benefit in that it's going to go in and like a little green beret, it's going to seek out the areas of the good alveoli, not the bad, the good alveoli, and provide some alveolar enlargement as well. So alveolar distension. So it's going to open that up to the good alveoli, which is going to help you hopefully reduce PEEP. So it's good. It's good. We need it. And a lot of our ARDS patients we transported before were on pulmonary vasodilators for that reason. Any question on that? Those are pretty easy. So they need to be, just like Dr. Tan said, they need to be on paralytics to prevent asynchrony and triggering issues. Expect them to have some anti-inflammatory meds because, just like I said, it is a very inflammatory process. Albuterol is not proven to be beneficial. And why? Why is that, guys? Why is albuterol just spitting in the wind here?
Weren't we talking about we really don't have a bronchial that, like...
Yeah, it's an alveolar problem more so than a bronchial tree problem, right? And so the albuterol is going to do what? It's going to help those bronchial tree inflammation and swelling. So not going to be beneficial here as much. So inhaled nitric oxide is going to be great because nitrates promote bronchial and pulmonary capillary dilation. And of course, VV ECMO therapy as well. We know that. Talking about Flolan, it can also go by the name Velitri, but the trade name, I guess, is epoprostenol. It works very fast, 1 minute, but it also, if you take it off, immediately stops working. It's a severe vasodilation of the alveoli. And so, like I said, it seeks out those good alveoli and improves those. Big thing to talk about is the driving pressure. So let's remember driving pressure. So how do we measure driving pressure, guys? Anybody tell me? It's right there, but tell me. Yes. So we need to get a good P-plat, right? On the Hamilton T1s, can we get a good P-plat?
No.
Well, we can, but we can't. I mean, it's I don't know how to answer that question really, but it does provide a calculated P-plat, but it's supposed to be pretty accurate, but it's not in a total P-plat because we're not stopping flow, right? We need to look at static compliance to measure a P-plat, which means the sensation of any air movement. And the Hamilton 10 does not do that because there's no volume control option to it. So we can get somewhat of a compliance, static pressure with the compliance plateau pressure. We got something. Then what you want to do is look at your PEEP. And so you subtract the two. And as long as that number is under 15, that's what they figured that we should go for. And they did studies on this, obviously, to evaluate what that number should be. And they came up with a pretty good study that said, as long as your PEEP or driving pressure is under 15, you're not causing trauma, barial trauma, volume trauma with your ventilatory efforts, with your inspiratory pressures, okay? So driving pressure can be used to evaluate if the lungs can handle the tidal volume given or not. So in other words, a driving pressure that is high is telling me that my lungs are less compliant than I think they are for that tidal volume that I'm providing. Does that make sense? Obviously, the tidal volume is the offending agent. The plateau pressure is reading higher because the lungs can't take the pressure. So it's going to give it back to the ventilator in volume. And the ventilator is going to say, oh, I'm getting volume back. That must mean there's pressure over there. So it's going to read that high pressure throughout the circuit. And it doesn't understand why the volume is coming back. It's just not going in. So it's going to read as a pressure problem, right? And so we're going to get pressure changes. And so driving pressure is a good measure of how to determine whether my compliance is good or not with the volume I'm given, right?
For our vents, just to make sure I'm doing it right, we're taking the delta P.
Yeah.
We're subtracting.
So it actually gives you a driving pressure on the vent. It's through the driving P, delta P. So we have an example. So we have patient number 1, for any given volume of air, I don't care what the volume is, he's got a P plot of 18 and PEEP of 5, so that means driving pressure is 13. For a different patient, for a given volume of air, he's running P plots of 33 and a PEEP of 8. So what's his driving pressure? 25. And so that's obviously telling us what?
It's not, it's, I don't want to say compliant, it just means that you have less compliance. It's stiffer lung, right?
Yep. So what's that telling us in regards to tidal volume?
We got to drop it.
It's telling us we're giving too high tidal volumes for the lung condition the patient is currently in. It is. It's spitting it back at us. High plateau pressures greater than 30 are going to indicate alveolar trauma because the pressure or the volume is too high. In this case, it's the same thing. Pressure is volume, they're both high. So we need to do something, right? This is indicating there's compliance issue in the lung and we're using dangerously high tidal volumes, especially if we're in volume control ventilation, right? So what do we do? Which parameters are we looking at? Well, we got to lower the P plat. How do we do that? What's the first action we should take? Lower that tidal volume, right? And then raise respiratory rate if you've lowered it enough to affect ventilation. If you're making small changes in tidal volume, you don't have to really worry about the respiratory rate. And that's why we teach you what here at SCCAD? What are 2 things you're measuring on every patient you pick up?
Their ideal body weight and tidal volumes.
So get a tidal volume and a minute of ventilation. Every patient you pick up. Those are 2 things you should be assessing. And I like to see documented in the narrative, guys, that you guys done that. Right? And I do see tidal volume changes in a lot of you guys' transports because you guys are assessing that. But I want you to assess and look at, hey, my patient's tidal volume was this, minute ventilation. Because if it's off, I want to ask the RT, why is the minute ventilation 10 liters a minute? It's okay, but tell me why. Oh, that's why, right? We want you guys to make that correlation. Increasing the PEEP. What would increasing the PEEP do to lower driving pressure? Why would it decrease driving pressure by increasing the PEEP?
You're taking, well,
Stiffen the lungs, the pathways,
yeah.
open.
Does everybody agree with that? So Donnie said that we're providing more tidal volume to be delivered because we're enlarging the alveoli. Does that make sense? Is that accurate?
Sound right?
Yeah, if you increase
So you're increasing surface area of the good alveoli and to allow more tidal volume to come in. Okay, and that's basically what's going on, but can you see a problem with that?
Yeah, it's going to change your P plat probably, and it's going to change your minute ventilation when you adjust the P.
You know what the problem with that is right here. Not all alveoli are good. And so the PEEP that you're giving in is going to the whole lung. It's not isolating itself. And so on the top one, on the left, that's a normal lung. And then the bottom on the left, that's a normal lung. But on the top right, you've got one alveoli that's good and one alveoli that's bad. And by increasing PEEP, what's happening is we can increase the good alveoli, but we're going to have a problem with the bad alveoli. And so now what's doing is the pressure that's backing up the bad alveoli is going into the good alveoli. So we have a problem here where we may be over-distending our good alveoli by giving more and more PEEP. Now, if we have to, that's the treatment module, but it's something we need to think about, right? So we could be increasing the pulmonary pressures in the lungs that are affecting the good alveoli by over-distending them, because the bad alveoli can't take that increased PEEP. It's going to translate somewhere, and it's going to translate over to the good alveoli, right? So this is why driving pressures are so important, right? And the lung compliance. So again, in low compliance states, let's keep our tidal volumes low. Let's start at 6. If we need to go as low as 4, that's fine. Let's go to higher PEEPs, but understand that PEEPs can be very dangerous, right? PEEPs can be very dangerous, and that increases intrathoracic pressure, and that we may have some alveoli that are shut down that can't take excessive PEEP. And it's going to translate that pressure over to the good alveoli and possibly cause damage. And we want to make sure that we are in a good FiO2, right? It's vital that you understand what condition you're dealing with. That means look at the x-rays when you pick up your patients. How many people ask to look at the x-rays? Raise your hand. Yeah. I mean, you have every right to look at every piece of information on that patient that's been done to that patient for all eternity, okay? I mean, not really, but you know what I'm trying to say, for that present illness. So get their labs, get their chest x-ray, get their CT, converse and discuss with your nurses and your physicians on getting a care plan, because you and you alone have taken over that patient care and to provide patient care for the next 20, 30 minutes. And don't be that provider that's like, I don't know what's going on, right? And so know what the pathophysiology of the ventilator patient is. And so when you understand that, you can make the appropriate changes in management to your patient, okay? All right, that's part of being critical care paramedics.
Before we jump into the Nicardipine talk, just wanted to put a little summary of the case that we just did. Like I said, I've seen lots of sick ARDSers, but man, that was pretty bad. So really nice job. And I just want to emphasize one more time that our job is to be that seamless transition of care from one ICU to another, really. And I think we did a really nice job of doing that. That was a tough, tough case. And tons of teaching material in there. Things I wanted to tie up, couple loose ends. To be clear, in COPD, for example, which are highly compliant, the terminal bronchioles do have some injury early on, but the alveoli itself will also be destroyed. In fact, that's the hallmark of advanced COPD. The alveoli lose its elasticity to the point where it can't normally collapse during exhalation, which is part of the problem of causing it to be trapped, right? So in ARDS, the opposite, where it's low compliance, the inflammatory process can destroy alveoli as well. The hope, of course, being if we intervene early and say take the load off of the lungs through VV ECMO, things like that, we can bridge that patient through the worst of the inflammatory process and save their lives and prevent damage that is irreversible of the alveoli. Does that make sense? But we're hoping that early on in the first 36 to 48 hours of this process that we can start recruiting enough with more aggressive PEEP so that it does not become permanently destroyed, if that makes any sense. Now, having said that, we had Chief Stewart did a super nice job of showing the mathematical calculation of driving pressure, right? The difference between the driving pressure being probably the better thing to ask when you are picking up this ARDS patient is not only what is their tidal volume, but what is their driving pressure, because that really is probably the best kind of bedside marker of mechanical stress on the lung. Does that make sense? And so by being a little bit more aggressive with PEEP, sometimes what are you doing? You're simply decreasing that difference between P-plat and PEEP. Right, so P-plat being your pressure in the alveoli at the end of inspiration, PEEP, what's the pressure at the end of expiration, and that difference is your driving pressure, right? So
if you can work both sides of the equation to keep the driving pressure less than what? What's the magic number? 15, based on ARDS data. The mortality rate skyrocketed when it was above 15. That's probably there were many foundational findings from ARDS data, but that was probably one of the biggest revelations, was 15 is the magic number. You keep that driving pressure of 15 or less, mortality is significantly reduced. So whatever you can do on both sides of the equation to close that gap, if their driving pressure is 20 or 25, what can you do to close that gap? Well, you can reduce tidal volume, right? If you're, because I assume all of you are already using 6 cc's per kilo-ish, man, you can go to 5, you can go to 4, so you're bringing that gap down, and then you can increase the PEEP a little bit, so now you're decreasing that gap even more to get it to 15. And that's the other thing that ARDSNet, that I think was very valuable, what it did, was that it taught us, a lot of clinicians would kind of randomly pick PEEP numbers unrelated to FiO2. Where ARDSNet said, actually, you should do that based on FiO2. So if the patient needs, if you're bumping up their FiO2, you should almost always bump up the PEEP with it to go so that, I think if I remember the table right, it was like FiO2 0.3, your PEEP is still 5 to 10, but by the time you get to an FiO2 of 80%, you should already be in the 18 to 20 range. FiO2 of 100%, you should be, I think they maxed out at 24 in the ARDSNet study. Was it, what, 24? Yeah, on the PEEP, okay. So, but again, physician driven, if they think that this patient can go a little bit more, like our case study, he hit 30, but it worked, well, you're riding that border, you know, between barotrauma and recruitment, and it's an art and a science. The science says, as FiO2 goes up, your PEEP goes up to decrease that delta between PEEP and P-flat and PEEP, but it's the art is how much, and that just comes with looking at the patient experience and gestalt, right? So it really is, I wish we could say it's a very discrete table, if this then that, but it's kind of, if this then kind of do this, but how you get there I don't know, and that's the art of medicine, right? So that's why it's the practice of medicine. So I wanted to make that distinction. And then I'm glad that we brought up whether the patient was prone or not. And I don't know if you heard at the break, the patient was in fact prone in our case study. And so the question became, would I be supportive of 64 making the decision to prone out a patient? The answer is yes, but, and what I mean by that is, and this was a really good discussion during the break, if you've never initiated proning out a patient on event, it is an event, right? It's not 3 or 4 people, hey, help me like log roll this patient. It is a choreographed event, and the best, most smooth ones I've seen involve at least 6, if not 8 people to do it smoothly and safely and choreographed. And so for that, that's the one reason why the first but is yes, but 9664, you need to get buy-in from the sending facility, say, here, this is why, I know it's only 30 miles to Big Barns or whatever, but it's gonna be at least an hour before we give final handoff, maybe 90 minutes by the time we actually get there, logistically, load, unload, travel up. I mean, waiting for the elevator at Barnes is 30 minutes by itself, right? So, I mean, let's be honest. So it'll be an hour and a half to 2 hours before we're actually done, right? So it ain't a quick 30-minute ride to Barnes and we're done. So I think a lot of sending facilities don't appreciate that. And so you let them know, listen, this is not a quick transfer. There's nothing quick about this transfer. So this patient is not doing well. Can we consider proning them out? If you can get them to agree to that, then it's going to be done there before you leave with 8 people. The second reason is if you arrive at the receiving facility and they're proned out and like you tried to do it en route, they're not going to be happy because it's also an event to receive a proned out patient. So for those two main reasons, I would say absolutely 64, if you feel like that's what the patient needs, I absolutely support that, with the caveat that do it before you leave and make sure that they update the receiving facility that they're going to be prone now. Make sense? Second, the other thing is, to that end, make sure that they are appropriately sedated and, frankly, paralyzed. In the first 36 to 48 hours of management of severe ARDS in particular, you want them to be paralyzed. Now, it's not good to keep them that way throughout the ICU stay, but you should acutely, and I think during transport, as long as they're well sedated and pressures can tolerate it. The question came up, well, do we give them the bolus or just start the drip? And I think if you're not doing RSI, you don't have to give them the full induction dose, but sure, you can give them a little bit of 10 or 20 milligrams and then start the drip of rock. I think that's perfectly acceptable. And then the other good question during the break was, well, how do you kind of know? And to me, the answer is, what I look at is the dyssynchrony resolving? Are the double triggers going away? Do they appear to be more, are the alarming stopped? Right? So those are all things that kind of let you know that you're at the happy place where you want to be with your drip. I think, especially with our case study, driving home that clinical pearl, that understanding driving pressure to be your quick and easy bedside assessment of that mechanical stress on top of tidal volume is really going to be key, because I think all of you are really good about using tidal volumes that are in compliance with lung protective strategies. But looking at driving pressure as your actual main marker of stress on the lung is something that I think is fairly new, or at least something that we can do better about, being more automatic about thinking about. And so that'll be helpful. Cool. Any other questions?
I got a logistics question. In
Yeah.
the big barns, does every nurse have a code blue swiper for the elevator? So like for a patient like that, you want to, hey, I want to bypass this wait line.
That is a really good question, and I don't know the answer. I don't know if everyone has. I know that the ACT team does, the acute care team, ACT, but I don't. In fact, I'm pretty sure that not everyone does.
I don't know if like the triage nurse, like, hey, I need to get upstairs, can you badge me up? But
Yeah, I mean, you can always ask. I know security probably does. So if you happen to see one of them, say, I got a critical patient, we need to go. Call me a car, let's go. Call me an elevator, let's go. So, all right, Nicardipine, Chief.
Well, thank you, Doctor.
Yeah. Oh, I'm sorry, you had a question?
Yeah, just on dosage, or for a rocket ring infusion, what would dosage be on that?
Well, shoot, I always have to look that up. What's our normal infusion that we start rock at? One? Is it one? Yeah, that's fine.
For a continuous infusion?
For a continuous infusion?
Oh.
Is that one? Or
For the infusion, it's, I don't know if we've ever identified that.
it was, I know it's a lot lower than that. Let me double check on that and see what we.
Most of the time we have most of them are on Nimbex when they come from the facility.
Will you have to raise that dose because it's
I had it back once. It's either Nimbex or VAC.
Nimbex or VAC? Okay.
But we need to figure that out. We do.
I know that Rock does have one, but if they're already on VAC at the hospital, then just continue that. I'm not saying switch by any means. I was talking about if they're not already on a paralytic and we want to initiate it, then we can initiate our own drip. I'm fine with that.
Is
Yeah.
it in the Sapphire? It may already be in the Sapphire.
I thought it was too. I thought it
It
was
may already be.
pre-programmed.
Because we updated it completely.
8 mics per kg per minute.
If not, then we can certainly get it added.
If you're level 2 or higher credentialed, you carry a bag that has medications that are not normally on the ambulance. The 3 that they carry are phenylephrine, nicardipine, and dobutamine. And so they're authorized to use those drugs under certain circumstances. The phenylephrine can be used on 911 calls or IFTs, and then dobutamine and nicardipine can only be used on IFTs for now. And so we had 2 instances in the past 30, 45 days where, and one of them was Donnie, right? Who administered nicardipine to a patient. And so I kind of want to talk about that case and then kind of review what nicardipine is and why we would use it, just real quick here. So as we know, nicardipine is a calcium channel blocker. It's very selective for cerebral and coronary blood vessels. So cerebral and coronary, so not pedal. It's a pulmonary arterial vasodilator with a small impact on preload. Now, what medication can you think of that starts with an N that involves nitrates that has a big impact on preload? Nitroglycerin, right? So nitroglycerin is very dose dependent. It's a very potent vasodilator, which is why we give it in coronary problems, right? But it also has some or arterial dilation properties as well, so it can reduce afterload. But this is a very potent arterial vasodilator which has a small impact on preload, so it's much safer in that aspect. It has a rapid onset, shorter half-life, so there are hemodynamically safe parameters to that drug. And we would advise you, if you're going to do it in the field on an IFT, to always get guidelines for blood pressure control management, right? And so I've already worked on it. I just haven't put it on Dr. Tan's desk yet. Guidelines, CPG guidelines specifically for strokes and how we're going to manage those. And they've showed you months ago, Dr. Tan, but we need to get it back out, dust it off, and put it out in circulation with your approval on specific guidelines, BP guidelines. If you don't get them from the ER physician or downstream, what we want you to do to manage your strokes with nicardipine. You can even call downstream, as you guys know, and get an order from them as well. But if you are starting nicardipine in the field, then we definitely want you to get an order of some kind for a blood pressure parameter, okay? So call the ER, call downstream, but get some kind of order. We're not physicians, we don't make those decisions. Let's get a physician on board with it, but you are authorized to start that medication. And we'll go over an instance where someone did. So it's approved for transport only, not approved for field use. The indications we're going to find is like aortic dissections. We want to keep their systolic blood pressure generally below 120. If they're in a hypertensive emergency, systolic blood pressure less than 160, those would include preeclampsia and eclampsia. Of course, don't start anything on those patients without contacting medical control first. And then obviously hemorrhagic and occlusive CVAs, we got a lot more leeway with that. And that really depends on the type of bleed that's going on. But generally, we're going to be looking around 140 systolic. If we are going to start it for CVA, we want you to start low. There's 2 doses you can pick from. They're both in the pump. You can do the mics per kilogram per minute, or you can do the milligrams per hour. It doesn't matter which one. Start low, titrate up, Q 5 minutes. And so you get the desired effect. Otherwise, if you're not sure where to start, call downstream and get an order to do that. But we'd like you to start low and titrate up. It does work pretty quick. Nicardipine is fast acting and medication, so you should start seeing results, and you should dial them in pretty quickly. To mix it, we're going to place 1 vial, which is 25 milligrams, in a 250 D5. It's preferred to use D5 for nicardipine, and we carry D5 and NS, so that you get a concentration of 0.1. And again, there's your diffusion max. We want you to max at 5 and 15. And remember, for nicardipine, there's no bolus dosing. Okay, so here's a call that was run. This was Adam's call, Donnie, I'm sorry. He had a really good one. So he went on a critical care transfer, check this out, for I think a 70-year-old male patient who who suffered a hemorrhagic CVA secondary to TNK administration. Now, why did they get him TNK? Because he went to the cath lab for a supposed cardiac lesion, and while he was there, he had a stroke. Okay, so then they brought him to the ER, or they thought he had an occlusive CVA. They brought him to the ER, said, "Oh, you're having a stroke. Here's TNK," and then he ended up having a brain bleed while he was in the ER. And so the patient was being transported downtown to get him the heck out of there and get him some neurotherapy. So he had cryoprecipitate TXA and Amicar infusing at the time. We're going to talk about what Amicar is here in a minute. The patient did require a ketamine for agitation and for sedation because he was pulling at everything. So they provided some ketamine. During transport, these are his blood pressures. So I think they started off in the ER as 179/109. He had nothing else hanging other than those 3. They started getting pressures in the truck during transport, because we know that during transport, a patient's blood pressure is going to rise. Actually, what it normally does is lower, isn't that right? Can I get a witness, right? It's terrible. But for this patient, it did rise to 191 over 110 and 186 over 85, 191 over 91. At that point, Adam decided to start an Nicardipine infusion. I guess, Dr. Tan can throw in here, but I think that decision was sound and appropriate at this point. Would you agree, Dr. Tan? Once he did, he started getting pressures in the 160s and 150s, which is the target blood pressure. So what we want to do is remind you of the caveat of the responsibility of lowering someone's blood pressure. It could be a dangerous thing. We're really entrusting you guys with the ability to do that with some pretty potent medications. In order to do that, we need to do that with knowledge and with safety in mind, okay? So we know this. We know that we just cannot lower someone's blood pressure because it's super high on a whim and just get it down to the target blood pressure within a minute. We know that, right? We don't have to explain that. We know what that would cause. And so where's the parameter, though? We need to give you some kind of thing to shoot for, and we're looking really not to lower that systolic blood pressure more than 20% in the first hour, okay? Now, we don't have them for an hour, right? And so we're really looking for you to lower their blood pressure no more than 20% in the time that you have them, okay? So if we just put it there. And so what happened at Adam's call? Well, he started with the systolic blood pressure of 179, and he ended with the 153. Okay, he had him for about 30 minutes. So basically, he kept the systolic blood pressure above 144. So if you take 20% off of 179, you're going to get about 144 and 145. And so he did really well at not lowering that blood pressure too fast, too quick, and to maintain a good range there. Now, Dr. Tam may throw in here and have something different to say about it.
No, that's the biggest problem. The biggest mistake is not watching by how much you reduce it. So.
Yeah. And I want to see that calculation in your narrative. Dr. Tan and I need to know that you're considering it and that you've calculated it and know what your hard stop is. Okay? So please put that into your narrative from now on. If you're administering Nicardipine, we want to know that you know where your hard stop is. Nicardipine is fast acting, but it's also kind of fast off too. So it's good. So down titrate it immediately, even stop it. You guys have all stopped infusions before during transport, no big deal. That's why we start low. We start low, we titrate to effect, and then we knock it off when we need to. Okay? Any question on that? Any question on how to manage and how to figure that out? It's pretty simple. Okay, when we come to Amicar, we want to mention it because it's something that we don't see a whole lot, but it's a very important medication that we might see. Amicar is another name for aminocaproic acid. You may know it by that name. It's actually an antifibrinolytic medication used primarily to treat acute bleeding from fibrinolytic states. It has a lot of uses for thrombocytopenia and other uses for cancer patients with bleeding, things like that. But we're going to see it on patients like this. And so the patient received what? Remember, he received T and K. And as a result of receiving T and K, he had a brain bleed. And so this is given in response to that. Okay, he was also given TXA. So what is Amicar? Well, when you think of Amicar, think TXA. They're pretty much exactly the same thing, okay? They are primarily lysine analogs that block the lysine binding sites on the plasminogen. If you went through the course here at SCCAD, you should be well versed on the lysine receptor on the plasminogen molecule, and that's what it does. It comes in and blocks it. And so plasminogen cannot change into plasmin. The purpose of plasmin is the only thing to do is to cut fibrin up, which is the clot, into little pieces so it can dissolve, right? And so here's another look. On the left is normal fibrinolysis, where plasminogen will bind to your TPA, and then coming down, and because they are able to bind together, they're going to chop up the fibrin. TXA or Amicar will inhibit the lysine binding spot on plasminogen and block that binding. And so TXA or Amicar cannot cut out fibrin. And in this call, I wish I wrote more about it. They actually stopped the TXA to give the Amicar, which is interesting because TXA is a much more potent antifibrinolytic than Amicar is. But they stopped it, TXA, to do that, which I thought was odd.
It's odd to use both together.
And that too.
I've never seen
But
them both together.
I think because of the bleed may have been so severe, the head bleed they had, it was so severe, I don't know.
Yeah, but it's not like you're adding a different mechanism.
But I looked it up and it's indicated to do both.
Well, you can.
You can, okay.
But it's just, that's like giving ibuprofen and
Right.
Why would you do both?
But they stopped the TXA to give the Amicard, then resumed the TXA, which was odd.
Yeah, but TXA is.
Yeah, TXA is much more potent than Amicard. So Amicard does the same thing, but TXA is like 10 times more potent than Amicard is, which is why it's the preferred thing to give for the bleeding. You don't see Amicard out there very much. They also gave cryoprecipitate for the same reason, because they needed to replace some clotting factors, right? And so if you ever see Amicard, now you know what it does and how they're going to use it. So we don't have rise time on the Hamilton. We have what's called a pressure ramp. And our default pressure ramp is defaulted to 70 milliseconds.
Oh, that's the P ramp.
That's the P ramp. And it's already defaulted low. That's low. A normal patient would definitely be able to take in a breath faster than that or slower than that. But we've already lowered it down. So really, the only thing we can do is lower it down from 70 to 50. You guys were in NIV, not NIV-ST.
We were in SC, I said a rate.
Oh, because now it's in pressure control. Okay. Anyway. Okay.
It's because it wasn't breathing.
Yeah, but it should. It won't change the PCV in NIV-ST. That's something else we need to think about. So let me show you. Okay, so when you're in NIV-ST and we set the rate. Okay, here we go. So we set the rate to 12, right, which it is. Now watch what happens if my patient goes apneic. So I'm going to breathe a couple breaths here. This is me breathing. Life is good. And then I go apneic. So 1, 2, 3, 4, 5. The ventilator kicks in. It keeps it in NIV-ST though. So in this mode, it's not a true BVM like you would. It's going to provide breaths for you, but as soon as it determines that the patient took a breath, it's going to go right back out of it immediately. Okay. Now the difference between the two also is on this mode, I cannot get it down to below 0. So can I do CPAP in this mode? I can't. Because in order to do CPAP, I need to have a pressure support of, like Chuck said, 0. So in order to do that, I need to go to my modes, go to NIV, confirm. When I see there's no respiratory rate there now, that's interesting, isn't it? So how does the vent go to know now how to breathe for me if I go apneic and NIV?
It'll switch to the PRDC line.
It'll switch, but at what point will it switch?
Whenever it's set or falls at.
Well, where's that setting at? How do I manipulate that setting? It's not respiratory rate because that rate is gone. Well, no, it's in the alarms. So basically, so you go to alarms and you go to your apnea time, and that's set for 20 seconds. So in this mode, I'm just going to, for training, I'm just going to lower it down to 10. Actually, it only goes to 15. So here I'm breathing in NIV. I'm in CPAP, so let's put it down to 0. Boom. So if I'm in 0 pressure support, then what am I manipulating in CPAP? What value? My EPAP, which is PEEP, right? So I'm going to turn my PEEP up to a minimum of what? Well, 8. 8. Let's go with 8, guys. 8 to 10 is generally where we want to be for CPAP. When in NIV, I can turn the pressure support to 0. I can turn my PEEP up to 8, and now I'm providing. So if I go apneic now, in 10 seconds, the vent's going to kick in, but it's going to be in what mode? PCV. So it's going to be in pressure control ventilation, which really then now is an actual BVM mode of ventilation, because it's going to operate independently on its own. And so there it goes. It's going to give you an apnea ventilation. It's going to PCV. It's going to alarm at you because it's telling you it's changed modes, but now it's in an invasive mode, an actual invasive mode. So we can use this now, so we can keep that mask on our patient and provide BVM support for pre-oxygenation. Okay, so if you want to do good pre-oxygenation of your patient using the monitor, NIV probably is your best mode to do so.